So we have plenty of time now to take questions. We're going to prioritize the questions that have been in the Q&A. So I know there has been some discussion in the chat, which I'll try to look through and synthesize. But if you could please also transfer a question to the Q&A directly, we'll try to address some of those. So one of the attendees did ask that if each of you, when you were getting BCG, was it always a complete dose? This is definitely a big concern right now, and we don't want to dwell on that issue necessarily, but just find out kind of each of you if you knew you always got full dose BCG.
I did, Doug, I did.
I believe I did.
I did not. I had
And yes,
doses, but about 1.5 of my maintenance cycles were half doses.
and this really did become an issue in 2019 and has continued since then, related to production shortages worldwide. And there are a lot of ongoing active efforts to change the supply, but it's highly variable across centers and sites and regions of the country. And there's really not a rhyme or reason in some instances. But what I will say is that Beacon, in conjunction with the American Urological Association and the Society of Urologic Oncology, created some guidance for clinicians, and you can reference that. It's readily available and pretty accessible in terms of easy to read in terms of what is recommended. And right now there are some adjustments being recommended to prioritize full dose BCG for the highest risk patients, and then to use reduced dose BCG for maintenance therapy in those high risk patients. And then there are some other adjustments being made for intermediate risk patients. So I would encourage you to access that. It's on the Beacon website and the AUA website, but that is an ongoing thing that is being studied and monitored. And there's been a great clinical trial that has just finished accruing that may give us some more answers, and potentially another BCG strain available in the US, maybe within 1 to 2 years. I'm gonna say, one question was for Doug. Did you have any side effects to gemcitabine and docetaxel so far?
No, Jennifer, and I thought about that when I was talking about it. I wanted to share that with people, that not everybody is as fortunate as I am. I virtually have no side effects at all. I tell my nurse that puts it that if I don't set my timer on my phone, I would forget it was even in there. So I'm very fortunate. I've had no side effects at all, and the drugs appear to be effective.
And these two drugs are given back to back in the clinic, just like BCG or mitomycin. And this is based on multiple centers that have done studies in patients with BCG unresponsive disease, like the condition we're talking about today. So someone did ask, what is Keytruda? And I want to answer on behalf of that. It is pembrolizumab, and it is a systemic or intravenous immunotherapy drug that is given typically in the US by a medical oncologist. And it is FDA approved now for just this entity, which is BCG unresponsive disease. And we are very grateful and happy to have more options that are not cystectomy, but it is still not something that is on the forefront of every urologist's sort of knowledge base and toolkit. So I would say this is, again, kind of bouncing back to the role for additional opinions. And it's a complex conversation now to have with a patient with this disease state and talk about all these options. Keytruda, which is pembrolizumab, cystectomy, which is still the gold standard sort of textbook answer, and then salvage intravesical doses of different agents like gemcitabine and docetaxel. So let's see.
Jennifer, just a quick question.
Yes.
Go on to that. Pembro is not generally recommended unless the disease is spread to other parts of your body. Is that correct?
Not true anymore.
Not true.
So originally, all of the drugs in that class, which are PD-1 and PD-L1 checkpoint inhibitors, there's multiple of them that are available for advanced bladder cancer, like you're speaking of. So metastatic bladder cancer, or bladder cancer that can't be removed surgically because it's advanced. So that has been the original source of approvals for those drugs in bladder cancer. But within this year, 2020, I should say, within the last year, Pembrolizumab was studied in Europe and in the United States in non-muscle invasive bladder cancer and is approved for non-muscle invasive bladder cancer that has not spread, that has come back after BCG. It does require, for say in my practice, for me to refer the patient to a medical oncologist for that discussion to talk about the potential side effects and risks. And then I still monitor the patient with cystoscopy. And so there's a lot of coordinating necessary at that point because we're no longer doing treatments in my clinic. But it is a very viable option, and patients receive treatment up to 24 months if there is response seen based on the checkups. Another question just about the gemcitabine and docetaxel. It is given in a very similar schedule to induction BCG, first for 6 weeks with weekly installations, and then monthly. And that is a similar schedule to treatment with mitomycin. Gemcitabine or mitomycin, or this doublet, we call it, with the 2 drugs, can be used in that sort of schedule. Let's see. This was an important question. Do you guys have any pieces of advice, and I'll wait to answer myself, for a patient who doesn't have a spouse or close family for support? What can be sources for coping and dealing?
I mean, this is Doug. I would encourage them to reach out to the Beacon network. I wanted to talk to patients that had undergone various different treatment methods, and Stephanie was very kind to make connections, help me make connections to certain people, and I found that incredibly helpful. And you'll find that people quickly become friends when they're sharing personal stories about what you're about to consider undergoing. So Beacon's fantastic. I have nothing but positive things to say, and I encourage you to utilize that resource.
I will put in a plug for the Survivor to Survivor, where survivors have been trained to be peer resources. So there is that. And then on the discussion board, Inspire, you can also ask a question and look for guidance, look for feedback, and look for input. And like Doug said, potentially develop some friendships over the wavelengths.
I would say another source of support that was very helpful to me was my home health nurse, who really gave me practical advice, a kick in the pants when I needed one occasionally, very practical advice, and just a lot of compassion and support. So I think, you can, and there are wound care ostomy nurses at most cancer centers, and they can be extremely helpful. So can appliance representatives, from different companies that manufacture appliances. They can be very helpful. They're not necessarily providing the same kind of emotional support, but sometimes what you need is to figure out what's going wrong with my appliance, and they can be very, very helpful too. So I would just add that there are multiple sources of support, and nobody will turn you away, believe me.
Technical, practical advice for managing the quality of life after this big surgery, or even the quality of life when you're going through intravesical treatment, is really important. And there's no doubt that the ostomy nurses are wizards. They're magicians and brilliant. So, I think those are great pearls. Did either of the patients who went through cystectomy consider the other reconstructions, such as neobladder or continent diversion?
Yeah, I actually did. I looked at all 3 choices, and I actually did a lot of research on 3 choices to ensure. One of the biggest things is when you're looking at which one you want to pick, it's very important to make sure that the doctor you've selected for your particular one is well versed in it. But for me, being a man, and I'll just spit it out there, being a man, I just did not feel comfortable if I would have had to catheterize myself. I would have had problems doing it, and neobladders aren't 100%. So, there's 20-25, I believe the number is 20-25% that, you can't empty it all the time. So that was me. And plus my age, I'm relatively young, and so I thought that was a better choice for me.
Yeah, I considered all the options, and I agree with Rick. I couldn't face the catheterization process. And fortunately, my doctor knew me very well by this point, and he knew what an emotional and anxious patient I am. And he said, I can do anything that you want, and there are pros and cons to each. I'm not going to tell you what you should do. But he said, my goals for you would be the quickest, easiest reconstruction and the easiest to manage post-surgery. And I appreciated that because I needed his advice and input. And I was really fortunate that he took my emotional state into account. He said, there's a longer learning curve with the neobladder and the Indiana or pouch. And he said, I don't see that as being in your best interest. But he didn't try to, he didn't say you have to do the ileal conduit. He was very honest with me. And that really made a huge difference to me, that he was taking my whole self into account. That was very helpful.
Definitely, it's a very individualized decision. Beacon also has some handouts you can download and read that offer more descriptions of each of the diversion choices and some specific questions to ask. And maybe there are some selection factors that help us offer certain choices over others, but ultimately it comes down to, do you understand the options and what's your goals, what's your expectation for your day-to-day, and how do you, it's again, quality of life is a big play in that. Let's see. Someone asked about UTIs after BCG, and I will say for men and women, interestingly, BCG itself will not cause urinary tract infections. There's some, reports that BCG actually treats bacterial infection that might be in the bladder instead of antibiotics. But definitely, if any of you can speak to side effects you experienced with BCG, what those were like, those side effects can feel like an ongoing, never-ending infection for some patients.
I had, I think, a pretty rare side effect. I didn't have any bladder issues with BCG, inflammation or irritation, but I think a relatively rare side effect is inflammation in your joints. And I had arthritis in my hip, and it was exacerbated, I don't know, 100 times by BCG. And I think that's one of the reasons that the arthritis has accelerated to be as severe as it is, causing me to have that joint replaced so that I can get back to being as active as Doug and Rick are. I'm jealous. I'll get there.
Wow, that is significant. Good luck with that upcoming surgery for sure. Could any of you talk about what the variation was and how doctors were open to new or different or clinical trial kind of options? Do you find that they were generally willing or not willing to go for things that were less known or established?
This is Doug. I just feel tremendously lucky to have Dr. John Gore. As you've heard, he's partners in this study, the cysto study, with Dr. Smith. And John is just an amazing personality. He's just so positive. He's so thorough. He's on top of everything. I come to him with some crazy questions about new stuff I read about, and he's usually well aware of it and talks to me about, the pluses and minuses. And so I'm just tremendously lucky and just feel, I've got a partner for the rest of my life when it comes to these kind of questions and decisions. So, yeah, he's a
Awesome
fantastic
clinician. Yeah.
Yep.
Wonderful guy. This is an interesting question, and someone asked about what defines BCG as failing, and I think that's been kind of a moving target for many years, and it had not been very well defined for a long time. And all these clinical trials studying different treatment choices as second line and third line were using different definitions, but that has since changed. So in 2016, and since, there have been a lot of FDA and urology organizations getting together to harmonize what these definitions are. And basically, you have to get adequate BCG first, which is BCG induction, 5 of the 6, and at least 1 BCG maintenance or another reinduction of BCG. So that's kind of the initial BCG treatment that's considered adequate. This individual talked about, oh, I'm sorry, it disappeared. This individual talked about going several years without recurrence. So actually, if you've been treated with BCG and had a long interval, at least 12 months of no BCG, and then cancer comes back, it may be reasonable to try to re-challenge with BCG, and that doesn't fall in the same definition of BCG unresponsive. So I hope that helps, but there are some, more outlines of BCG unresponsive definitions. There's also BCG intolerant, where you tried BCG, you had a lot of side effects, even reducing the dose or trying medications to help with the side effects didn't work. So you're off BCG because it just was not able to be tolerated. So there are some very specific individual questions about personal scenarios, and I don't think it's kind of the forum to go into individual questions, but there was a question about, yeah, I think that, I don't know if all of these participants can tell us if they're, on Inspire or available through Beacon as peer support.
Yeah, this is Rick. I'm actually on Inspire, and I don't want to say I go on there every day, but I do go on there regularly, and that was one of the sources that I used after my surgery, and and I was reading, as I said, that I was reading a lot about that, but actually that was actually where I found the University of Hawaii meditation clinical trial also. So, yeah, I'm on there, and it's a super site, and I think for the most part people are really helpful. There's a few people on there, and they're able, when people come on with questions, they just answer them so well. But yeah, I do participate in that, and amongst other things.
I'm actually a newly trained Beacon survivor to survivor contact person. Nobody's called me yet, so I would be happy. I would be happy to provide whatever support I might be able to.
Yeah, I'm not on any of the formal networks myself either, but am very happy to answer any questions people may have. I actually did it for a period of time following my prostate cancer surgery, which was really successful. And so I worked with several people diagnosed with prostate cancer, and for several years, and it was the most rewarding experience I've ever had. And so again, I would very much be willing to do that for anybody that wanted to reach out to me, and I'll happy to give you any support I can.
Thanks to all of you for being willing to be there for others, facing similar things. One question a little while ago did ask about what percentage of BCG treatment fails. And I would say that's really dependent on the initial factors that are part of your individual cancer, but in general, BCG works in 50% of patients who receive it initially. So there are, up to 50% of patients, depending on the initial stage and factors, that it may not be the right treatment, or it may not be effective. So this role for salvage treatment is still very real and very, very high need in all of our practices, for sure. Let's see. Morgan, please let me know if there's anything else you've seen. I want to make sure.
It would appear that all of the rest of our questions are either already been answered by our wonderful panelists, or are very specific to a certain type of treatment. And I am pleased to announce that we have our upcoming treatment talks, which do go into specifics of different types of treatments. Those can be found on our website at www.bcan.org/webinars. And you are welcome to register for the treatment-specific programs.
Awesome. Someone asked, well, I think I put it in a written answer, but Keytruda, pembrolizumab, does it cure or just delay cystectomy? And so far in the sort of preliminary or early, which is short term at this point, so far with that data, the response is that it controls the cancer and there's no evidence of cancer. In non-muscle invasive bladder cancer, cure is hard, but not seeing cancer on surveillance and how long you've been without any visible or detectable cancer is the goal. That's the outcome we're going for. So pembrolizumab is successful in doing that in a fraction of patients that are treated with it. And that's in the 20 to 30% response range that's durable.
Jennifer, Doug here. I just had a quick follow-up on that. There was some discussion, I believe, at one time about maybe considering pembro being instilled into the bladder. Do you have any comment on that?
There is a clinical trial of pembrolizumab with BCG, but if I understand, it's still given IV and BCG is given in the bladder, but I could be wrong on that. It's on clinicaltrials.gov.
Okay, thank you.
Let's make sure there wasn't anything else. This is as many of you have indicated in your own personal examples, this is a very complex, condition and lots of different moving factors. And so speaking to your personal urologist and then seeking other opinions is definitely recommended. Somebody mentioned blue light in the questions in the chat, and I think that is as available as the clinics. So not every clinic everywhere has it, but do each of you know if you've had cystoscopies with blue light either in the OR or in the clinic in the past?
My last biopsy, I believe John used blue light. So I've had experience with it. Mm-hmm.
Yeah, this is Rick. I actually had, when I went to UNC, I actually had blue light, but when I was at my urologist, as you said, Jen, they did not have the blue light technology. They were only using the white light, not the blue light. And yeah, if you can, I think it showed, from all the research I've done, it does show a lot more.
It's very useful, particularly if you have carcinoma in situ. It has historically, for the less than a decade though, but it has been available in the US for use in the operating room at the time of TURBT, but it is also newly available in the last year for use in the clinic. So that available technology is still kind of small and growing. And there's also narrowband imaging that's available on another type of equipment that can also help distinguish some of these indeterminate, hard to decide. So there's these couple of different enhanced cystoscopy techniques that are recommended and very useful. There's a lot of comments in the chat, at least to the panelists, if you didn't see that, saying that this has been very, hearing personal experiences was interesting and enlightening and so inspiring. Thank you for sharing. Proud of you all. So it's been a pleasure and an honor to speak with you and try to moderate this session. Morgan did answer also, there's a clinical trial dashboard on the website to sort by state and by type of bladder cancer. I know that clinicaltrials.gov is quite hard to navigate, not very user-friendly, but certainly Beacon has a way to distill some of that and make it a little more approachable. I think that's right now, trying to find clinicians who are familiar with clinical trials is still a challenge. There are big centers, not all academic, but many academic centers, and then some big, large group, we say large group practices where they're very busy doing active clinical research in bladder cancer. So.
Jennifer, this is Doug. One of the things I might ask you to comment on, because it took me a while to understand it. I mean, years after I was first diagnosed, but can you explain to the patients the difference between, a surgeon, urologist surgeon, and then a medical oncologist, just so they kind of make that connection? You've referred to it in the context of pembro, and I think it would help if they understood the difference.
Absolutely. Thanks, Doug. And we make it even more confusing when those of us who've done more specialized training also call ourselves urologic oncologists. So anyone with urologist or urology in their title does surgery, and they manage any of these diseases when they are surgically staged or resectable or need a biopsy. But if there's systemic treatment needed through an IV, typically, that is done by a medical oncologist who is a medicine trained doctor and then specialized in cancer and systemic treatment for cancer. And many of the ones we work with are specialized in genitourinary or urologic cancers. So a lot of terminology and labels, but there is definitely a distinction. And for this type of disease, it's becoming more important to have that collaboration and teamwork to manage it. Let's see. I will touch quickly that someone did ask if radiation has a role in these circumstances. And as of right now, radiation does not have a place for non-muscle invasive bladder cancer, and particularly for carcinoma in situ, generally because it's this flat, hard to find, kind of superficial cancer on the lining of the bladder. Radiation has often not been very effective, even when patients have been given radiation. Say they had invasive cancer and got radiation, the CIS is potentially resistant to the radiation, but radiation is currently not a treatment choice for non-muscle invasive disease. And for Keytruda, for pembrolizumab to prevent recurrence, interesting, only for someone who has disease that we're trying to control. It's not given for non-muscle invasive disease as any preventative type treatment, I guess.